welcome to our SPX talk in English. My name is Joep Pamen. I'm a board member at SPX. Thank you very much for joining us, even though we know you're super busy, but I'm sure you'll enjoy it. I have a quick public service announcement before we start. The annual SPX European Awards 2025 event, recognizing initiatives enhancing patient experience, is on April 10th in the lovely city of Liège in Belgium. You can still register for free on our website. It's open to everyone. And last week we launched the public vote. Watch the shortlisted applicants' videos and vote until March 26th to choose the public vote prize winner. You can do that through our website. All winners will be announced at the ceremony. So we'll start this interactive session with a couple of questions to get us going. Afterwards, we'll leave time for you to pose your questions. You can use the chat to formulate your question or just raise your digital hand. I'm sure most of you are used to that by now. So we are delighted to have Dr. Jason Wolf, President and CEO of the Beryl Institute, with us, despite the early hour for him. I think it's 6 a.m. where he lives. And he's our special guest. He's an expert in patient experience, organizational culture, and high performance. He's also the founding editor of the Patient Experience Journal, and he's authored numerous publications, 2 books, and plenty of articles on healthcare improvement. So I think we couldn't start with a better person. Jason, thank you very much for joining us. So I mentioned that you are the president and CEO of the Beryl Institute, but maybe not everyone knows the Beryl Institute yet. So can you briefly explain what you do, what it is you do?
Yes, no, I appreciate that. And just really a privilege, really such an honor to be with you. And I appreciate the invitation. I know these moments are important when we can bring our community together around the world. So, and I just want to say to the audience here, truly honor and appreciate the incredible work at SPX that it is doing to elevate the discussion across the European continent. And I think, you know, as folks that I see here that I know, like Vita and others, and show up the chance that we've had to meet, the ripple effects that you all create in the global conversation is important. So while your discussions may feel regional, they impact the world. And so it's always an honor to be able to be part of that conversation and be invited to participate. So I just want to say thank you up front for that. And it really does lend itself to what the Beryl Institute is. You know, Joep and I have been talking, you know, I'm a trained diplomat first. I'm a foreign service officer that believed the world could be better if we worked together. And I discovered in my days inside healthcare that we weren't always good at collaborating, honestly. Think about the word shared, obviously, right here in the title of SPX itself. And the idea that we could create a space in the world where people could come together without fear of the vulnerability, the ability to have a safe environment in which to have conversations, a community in which to join and learn from, was really the foundational ideas that started the Beryl Institute. Believe it or not, 15 years ago, just this month is when I left the delivery side of healthcare. So, and over this 15-year journey, we've built the Beryl Institute into a global community of practice, a community of professionals, patients and family members, solution providers and vendors who all champion the idea that if we can collaborate, share ideas, and learn together, and then put those ideas into action, we can transform the healthcare for not only the human beings that show up to receive care every day, but those who show up every day to deliver that care in the communities they serve. And so the word I come down to usually is collaborative community, and the opportunity to really bring people together in that effort has been our intent over these last 15 years around the world. And it's been exciting to see. We now include over 60,000 people in our community. 85 countries have memberships. Our content is actually accessed in 220 countries and territories around the world. So it is a global conversation that we're all part of, and really excited to be able to share that information with you. So. Jupe, I think you might be muted, my friend.
All right. Yes, thank you. So, Jason, at the Beryl Institute, if I'm correct, you've developed some guiding principles for patient experience excellence. Could you just briefly explain what these are?
Yes, it's interesting on a journey, a couple things, and I know we'll kind of come back to this too, I believe. When we first started the Institute, we felt it was important to think about a couple things. One, how you define this idea of experience as well, and I know we'll hopefully we'll speak to that. And the foundational definition on which we built it really led to the guiding principles. The way we framed experience as a community was the sum of all actions shaped by an organization's culture that influences patient perceptions across the continuum of care. And those simple words around interactions that we have, human being to human being, the cultures and the organizations we build, the perceptions of patients, family members, care partners, and all touch points across the continuum of care, well outside just the clinical space, is the grounding position for the guiding principles themselves. And what we realized is that people were looking for a bit of a structure just to understand. I will say right up front, at the Beryl Institute, we don't espouse a model. We don't suggest you should do these specific things. You have to find the right pieces and parts that fit for your organization, in your culture, and for your demographics and the health system structures in which you operate. But at the same time, I always ask the question, how many people here are human beings? And if I could see everyone's camera, I would assume we're all raising our hands. So there are some fundamental ideas, I think, at the foundation of that really are around the idea of guiding the conversation. And our guiding principles really come down to that foundation, that we need a definition, that we have to have leadership that drives experience, that we have to continue to focus on culture at the heart of that definition, and that we have to care for the healthcare workforce. And we have to do all those things before we can even deliver on a positive, safe, quality care outcome. And then we can work on partnerships with our patients, families, care providers. We can acknowledge that our experience that we provide starts well before anybody engages with our healthcare institutions to well after they leave. But then it gets broader into the communities we serve, that we have to understand our commitment to health equity, how we ensure the right access to care, and that we actually think about healthcare as beyond just treating of the illnesses that are in its midst, but how we really elevate the health and well-being of our communities. And so we sort of link that definition and those guiding principles in a way that ultimately help us elevate that discussion as well. And that's really important.
Great. Jason, just one quick practical note.
Yep.
Not all of the people attending are native English speakers. So I'm asking you to do the impossible, share a lot of knowledge and do it slowly.
Yes, so I appreciate it. It's my old follow. New York blood. I apologize. No problem at all.
Jason, I think we're all faced with economic conditions which are not ideal. How have you been working with the Beryl Institute members to still make the case for investments in patient experience?
Yeah, I appreciate that conversation. And I think this idea of return on an investment in experience is an important one. The idea that we've really come to, and over these years, and I think through the input and participation of so many of the people, even on this call, realize that when you can focus on the business of healthcare in multiple streams, right? You can focus on quality improvement as one stream. You can focus on safety issues as another. Workforce issues is a completely different thing, or even just the pure economics of getting people in the door or building consumer loyalty, having them feel like they want to come back specifically to your healthcare organization or your specific one in your national system. But what we've really come to realize and what we've developed through the community is that there is a true value case to a commitment of human experience. And when you think about this focus on experience, especially even in economic times that we faced in healthcare. We were worried about the stress on our workforce, even finding the right quality staff. That when you commit to experience, you actually drive, I believe, the four things that you're looking to achieve in healthcare. One really is you drive workforce value, right? You build opportunities for retention of staff and a place that's safe for people to work. That's an actual economic impact on an organization. You create a place where patients and family members feel value. So they are choosing you. You can continue to see a valuable engagement within your communities, and that you have active and safe outcomes as a result of that. That you actually see community value, right? The idea that healthcare is expensive, in particular on nationalized systems, right, where we have central systems of government, that it costs us, right? We may not always pay, quote unquote, for healthcare, but we do. And when we create healthcare systems that actually create health in our communities, that's also part of the experience. We reduce the cost burden on our health systems. We improve the economic opportunities that we have within our healthcare to invest in the things that matter. And then I do believe it has an impact on the bottom line. A commitment to experience actually helps us be more efficient. When we communicate better, when we reduce errors, when we create higher quality outcomes, when we focus on, I think, as Mathieu so eloquently, I'm glad you raised the issue and what matters to you, that when we ask people what matters to them, we actually shorten the distance to the best outcomes possible. And we can ultimately improve care overall. And so we actually wrote a paper in the Patient Experience Journal that kind of touches on this value case. And in addition, I think you kind of alluded to this too, my COO, Stacey Palmer, and myself wrote a book on this idea, the return on human experience, that actually speaks to the fact that a commitment to the guiding principles that we spoke to before, and a commitment to an intentional strategy around experience can lead you to significant outcomes, those very values that we spoke to. And I believe when you can make that case, it's a case-by-case basis, an organization-by-organization basis. So I know many people here on the call are in their own individual institutions just trying to say, it's important we focus on this here. But I think the ability to draw back those strands to the value of the people that work there, to the value of the people that we care for, to the communities that we serve, and ultimately the operational opportunities in our institutions, that there is a real economic value to a focus on experience at a relatively little investment. It should hopefully help our executives, our leaders that make these decisions in healthcare, see a different path forward in a way that this isn't just about doing a survey or ensuring people are satisfied, but it's about a fundamental mindset shift that can truly have a significant economic and operational outcome on what we do in healthcare overall.
So if I understand you correctly, Jason, you are kind of seeing a need to expand from patient experience into human experience. Maybe a follow-up question based on what you're saying is how do you envision the evolution of patient experience in the coming years? What do you think is going to happen?
And I appreciate that question. I think, in many ways we've spoke about this from the beginning, but just not explicitly. I think we have never not in healthcare been speaking about patient experience. We just haven't used that term until recent history, right? We have always thought about the care for the patient. We think things like the Osler method and the idea that we take a Hippocratic oath for those that are physicians, that we care for the people in front of us. I think we've also acknowledged that there's always been an experience in healthcare, whether we've called it that or not. People come to healthcare. They have an encounter with us. They have an experience with us. And I don't think any of us entered healthcare historically or up to this day with the idea that this is simply a transaction. You show up, we do something to you, and you leave. There is an inherent relational aspect of the work that we do in healthcare. And so if we come back to that point, that in healthcare, if I asked everybody we're human beings, we'd all raise our hand. We show up in healthcare, no matter if we are a care provider at the bedside, an administrator, if we are cleaning the garbage out, or we're working in the back office on financials. We all are human beings who show up to care for the human beings who need our help in healthcare. And so that lens kind of comes back to the very definition that we spoke to from the very beginning, Jeff, that at the heart of the definition of experience is culture. And if we realize that, we have to build places that work for people to be able to deliver on our promise in healthcare. And so this idea of human experience itself isn't really new. It's just also become explicit in a term, right? And so for the last 10 years now, we've been writing about and speaking to the fact that if we're going to fulfill the promise of that definition, if we're going to live to those guiding principles that we shared earlier, we have to think from a human experience lens, that to care for the patients and family members and care partners that are at the center of our healthcare system, we have to understand that we have to care for our workforce. There is a workforce experience that matters. And again, as I've alluded to before, our healthcare systems don't operate in isolation. They're not independent entities that are disconnected from the communities in which they live. You go to your supermarket, you go to your church or your fields for your, and the sports around you, your mosque, your synagogue, you're out there talking to people who engage with your health system. And so health systems, as we talked about before, really impact the health and well-being of the communities in which they reside. And so that level of community experience is also incredibly important, both from the economic factors that we spoke to before, but honestly from the most important things, that we choose healthcare to make our world better, to make people better one by one, and to impact the communities that we serve. And so those three levels of the patient and family experience, the workforce experience, and the community experience really all are part of this human experience that we've spoken to for a while. And the reality is we can't disconnect those pieces from each other. So it doesn't by any means, I think, diminish the fact that, the title of this organization, right, SPX, is Shared Patient Experience. That's the heart and essence of what we do, or that the purpose and mission of the Beryl Institute itself is to transform the human experience by ensuring the best in patient experience. But it has us think about the real implications for our actions. And I think that evolution is important for us as we operate healthcare, especially in a world where, let's be honest, sometimes humanity seems to be forgotten. And I think we have an opportunity, in particular, people who champion this work, and seeing so many faces and names that I know that do. We are kind of a bit of the term I like to use as a radical catalyst. In a way, we are stirring up the waters to not let people forget that no matter where we stand in the world, no matter what we look like or what we believe, no matter what language we speak or national identity we call ours, we're still human. And that's something we should honor first above anything else.
Great. Thank you, Jason. I think this is a good time to open up, the opportunity for questions. So if any one of the participants has a question, you can put it in the chat, as I see Heinrich has done, or you can raise your hand. But we can address Heinrich's question. I don't know whether you see it, Jason. So maybe quickly repeat it. So I'll let you repeat it. And we have another question from Rui, but let's take Heinrich first.
I appreciate that question. So just so that people can't or have not seen it in the chat, one point in improving experience is to find out the pain points, what's there for patients, what their need, wish, fear, aspire to. How do we go about that? I think I think in many ways, it's not even how we go about that. How do we ensure that happens? I think, it comes back to the context that Mathieu posted earlier around the What Matters to You movement and the incredible conversation there around shifting the discussion from one of what's the matter with you to what matters to you. And so as we think about finding out where pain points are, or the needs, wishes, fears of patients and family members, even those who show up to work, my biggest fear is that, and I think we've buffeted this, is that we got stuck in experience as something that was simply a measurement or a survey or a statistic around, how many smiley faces someone clicked as they walked out. So I think that calls on us to think about multiple levels of how we understand what matters to people, right? We have to understand the expectations that people have when they enter our health system. I don't think we necessarily do a great job about that. I believe, the ability to ask someone what they're expecting from their encounter and then telling them what we can and may not be able to do actually alleviates a lot of those issues right up front. I think we have to be engaging with people throughout the journey. I think back to the conversation on what matters to you, to understand why they're there and what are things are most important to them. I think we have to make sure that when people leave or are getting ready to leave a healthcare encounter, we ask them what questions they have, and what we can ensure they feel prepared to do when they leave. Many times, I think my family included, we've left appointments with a piece of paper or a good luck or I hope you feel better, and then we still wonder what we're supposed to do. So I think it's the simple human touches that actually help us. So I wish I could give you elaborate methods and approaches that work, but the things that I consistently have seen now over these 15 years is our ability to understand what expectations people have, ask them what matters along the way, ensure that we help ensure that they understand their health journey after they've engaged with us, and have them know that they can come back to us with the questions that they have. So rather than having the pain points appear in the midst of some journey, we're actually anticipating the potential that they are there, and we're getting ahead of the possibilities of what those could be for people as well. Oh, I see, Zup, you're still muted, my friend.
Sorry. I try to do
No
this to
worries.
minimize the background noise. So I hope it answered the question for Heinrich. We have a question from Rui. How does the patient experience research foster collaboration and influence healthcare policy or practice improvements? Can you give an example? You have to know that Rui is an assistant professor. So
I love that. Well, I appreciate that, Professor. Being an old graduate faculty member myself, I can appreciate that. And it's actually one of the reasons we started the Patient Experience Journal back in 2014, was the reality that, the evidence around experience was scattered in so many places in the world. And now we've have some opportunities for a central repository. I think, and I would hope you'd agree, that research isn't only for the outcome or the paper that we create, it's for the learning it creates during the journey. It's the engagement and participation of people along the way. And I'll give an example. Right now, we are in a major study around an idea called the Global Experience Measure to understand if we ask human beings a few common questions around the world, could we understand how healthcare is performing, regardless of whether we're in Liège, right, or if we're in Nairobi, Kenya, or Singapore, or Sao Paulo. And I believe in asking the questions that we ask in research, by engaging people in the conversation, we immediately foster collaboration. I think then we actually have to be more intentional in having conversations about how we read out what we find. So for instance, in the Global Experience Measure effort, what we'll be doing is we'll be taking every contributor that participated in it, and before we just write up our data, we're going to get in a collaborative, cooperative space and say, what does this mean to you? What do you think we found? What could we do with these findings to really make a difference? And so to me, I think it's not about the research for simply the research. I think it's critical to push the evidence and innovation, but it's around how we use those processes to bring people together to do exactly what you say, influence policy, change the conversation, and then translate that into ways it can be practically applied. One of the things that I'm most excited about, we just had an editorial board meeting with our PX Journal board, and some of our greatest academicians from around the world said the things that were most important to them weren't the fact that our articles were cited 50 times, but that we knew people were using that article to teach new healthcare leaders or change practice in their own organizations. And so I think if we can look at that lens of both impact from expanding evidence, but also impact in changing practice, then we're exactly doing what matters. So I appreciate that question, Louis.
Great. Thank you, Jason. We have another question from Vita, who I believe you know. He says that human experience is people-centeredness in definition of healthcare quality, though it is rarely in healthcare strategies of hospitals as equal component alongside patient safety quality. What steps should we take to raise awareness of human experience in a level it would be accepted in the same level? I guess how do you get senior people to attach more importance to
Yes.
patient
Well,
experience.
and I'm sure there's many of us here that grew up in environments of managing quality or quality checklists or safety protocols or those kind of things as well. I believe, and I think this is a universal truth that I've experienced healthcare administrators, of which many of us have probably been that as well in this room, that we operate on the tangible. So it's easy to have a safety checklist or a quality protocol or those sorts of things. Human experience, I think, and Vita, you're a champion of this, is a more amorphous concept. So we have to be able to translate it back to say, okay, well, in fact, to care for our patients, what's included in that sort of comes back to almost the experience framework that we talk about at the Institute. It's the quality and safety practices we put in place. It's the technology that we implement. It's a litany of things that actually drive the experience of patients and families. Similarly, that impacts our workforce. And I do think the angle that I have seen has changed mindsets, in particular in changing the discussion of acceptance, is really taking a moment to frame what we mean by human experience. I actually find, back to your earlier question, Joe, that the idea of human experience sometimes is easier for executives who haven't grown up in our patient experience space to hold on to than even patient experience, because many still see patient experience as the survey. Well, we do quality here, we do patient experience over here, and they're all now competing against each other. I think taking that human experience lens, Vita, and speaking about how all of the practices and protocols we put in place drive what matters to patients and families, addresses the needs and vulnerabilities of our workforce and the challenges that we face, impact the communities that we serve, is a reframing that I think people can get their arms around. And you can begin to align the more tactical pieces to the strategic idea that frames. And so that's what I've seen be successful. And I do think it's work, but I think it's possible.
Great, Jason. I think we're going to get plenty more questions, but I think we have time for one more. If you can tackle it very quickly. We have a question from Sandrine Junio, who says, how to measure the impact of patient involvement?
That's a great question. And Isabel, I see your question too. We can talk about that, I promise. At some point, if I know I'm honoring your time. I think the impact of patients' involvement is such a critical piece. So I think, we've got champions on this call that could probably even speak to that more, Mathieu and others. I think the reality is that we can't have a conversation about what matters in healthcare or about the best outcomes unless we engage patient and family voice. Measuring the impact of patients' involvement, first you have to get them involved. I think, we have to build strategies and structure to show when we create the opportunity for patient voice to be included as partners in their own care, when we create the opportunity for patient and family voice to impact the strategies of our organization, when we can engage patient and family voice and thinking about how we present ourselves to the world, that's how you can begin to draw strings. So I think what you have to be able to do is say, okay, most organizations haven't perfected the art of patient involvement. Nobody's got this down perfectly. But you can begin to show, okay, when we work on a project or we work on something in isolation from patients and families, this is what we have tended to see. But when we actually begin to incorporate patients and family members, care partners as partners, you can almost in every case see tangible differences in outcomes as a result. And so I think it's a bit of a comparative study. I think it's also, for some, still a leap of faith to do that. But I think it is not only the right thing to do, it's the thing that actually leads to the best outcomes in healthcare as well. And so I think we will see the outcomes that matter as a result of involving patient and family voice for sure.
Great. Jason, thank you for being so concise. I'm very sorry that we haven't been able to tackle all the questions. I'm sure that they can get in touch with you directly, Jason, if they want to. I saw that you dropped your email address in the chat earlier.
I'll put it back again.
You'll accept LinkedIn invitations.
Yes.
But I do want to respect people's timings. A replay of this talk will be available on our website. Our next talk in English will take place on a Thursday, exceptionally, not on a Wednesday. And it will be on the 17th of April. And our guest will be Adrian Gorecki, a leading patient advocacy expert in Poland and beyond, who will be talking about patient communication. For French speakers, if you have lucky enough to speak French, you can join us on April 2nd for a talk on the Patient Perspective Program at Johnson & Johnson Innovative Medicine. You can find, of course, more information on other talks and our activities on our website. Leave me to thank you very much, Jason, and all of the participants for being on this call, and we hope to see you soon. Thank you very much.